Hello everyone, welcome to week 3 tutoring. Today we're going to be talking about various subjects, particularly in the postpartum care of women. Please remember that we have postpartum hemorrhage, early postpartum hemorrhage, and late or secondary postpartum hemorrhage. Postpartum hemorrhage can occur anywhere from the moment they give birth to the child to up to 12 weeks after they have delivered. Okay, the primary hemorrhage is considered the first 24 hours. Any hemorrhage that occurs after the first 24 hours is considered late or secondary postpartum hemorrhage, but it can occur up to 12 weeks. Okay, it is important that in order for us to prevent this postpartum hemorrhage that we do our proper fundal assessment. The first hour, the fundus should be assessed every 15 minutes, the second hour every 30, the following 22 hours every 4 hours, and then after that, usually Q shift or Q 8 hours, depending on the organization that you work for. When we are assessing the fundus, what are we looking for? We are looking for the firmness of the fundus. We are looking for the location and the height of the fundus. Okay, in a perfect world, a patient who is 24 hours postpartum should have her fundus 1 centimeter below the umbilicus. It should be firm and it should be midline. Okay, if we have fundal deviation or where the uterus is deviated to one side, chances are it's because the bladder is full and consequently the uterus is going to be boggy. What does boggy mean? Boggy means soft, the opposite of firm. Okay, remember that when we're caring for a patient, your best partner is going to be your patient. You must educate them and have them palpate their fundus, have them feel it and see how it should feel. All right. So we want to assess definitely the location and the firmness of the fundus. What is the tone? Okay. If we have a patient that is bleeding or they tell you, oh, I think I'm bleeding a lot, the first thing you're going to do is go palpate that fundus because most postpartum hemorrhages occurs as a result of lack of uterine tone. Please note, if your patient is hemorrhaging, you are going to see signs of hypovolemia, but these signs occur when they've been hemorrhaging for a while, all right? Hypovolemia, they've lost a lot of blood. So what are you going to see? You're going to see a decrease in the blood pressure, increase in the heart rate because the heart and the body is trying to compensate for the decrease in volume. Respirations may or may not change. Regardless, the first thing we do, we want to assess. You want to palpate the fundus, and then you do your interventions. Remember, we have all those uterotonics. We have oxytocin, we have methylorgonabine or methergin. We have hemabate, also known as carbopros, and cytotec, aka misoprostol. And we will give those if there are no contraindications for the patient. For example, if your patient is hypertensive, we know we cannot give a methergin. Okay, so those are things you need to take into consideration. Note that women can experience afterbirth pains. Afterbirth pains will increase according to the number of parities that they've had, how many babies they've delivered. A woman who's delivered 3 babies in the past and now is having her 4th one is going to have stronger afterbirth pains than the person who's had 1 baby in the past. So, grand multiparous women tend to have more pain. Why? Or even women who have had like a macrosomic baby, a large baby. Why? Anytime the uterus is stretched out more than, a normal pregnancy, which occurs once you've had multiple babies. The body, there's memory, so it makes it easier for the uterus to stretch. So with every pregnancy, it stretches a little bit more and a little bit more and a little bit more. So it makes it harder for the uterus to involute into its pre-pregnancy state. So it has to work a lot harder, which means the contractions that occur during involution are going to be stronger, okay? Remember with the fundal height, day 2 postpartum is going to be 2 centimeters below the umbilicus. Day 3 postpartum is going to be 3 centimeters below the umbilicus, so on and so forth. When we're caring for patients in the postpartum setting, if your patient is Rh negative and their baby is Rh positive, you are going to administer RhoGAM within 72 hours of delivery. Remember, ROGAM is first administered at 27 weeks gestation, and then a second dose is given after they have delivered within 72 hours, if and only if the child is Rh positive. Before you administer this and any other medication, you need to make sure that it is necessary. So in this case, you want to confirm that your client indeed is Rh negative, and you also want to make sure that the child is indeed Rh positive before you administer a second dose of ROGAM. If the child is Rh negative, there probably is no need for the second dose of ROGAM, okay? When we are providing education to our patients when they're getting ready to go home, we must provide education for mom and the things that she has to report, and education on the things that she has to report for her baby. Also, we do this at the end, but when we're providing education in general, remember the maternal phases. You have the taking in, the taking hold, and the letting go. And the taking in phase is all about mom. The taking hold, then we can educate about baby. And then the letting go stage, they're really not with you in the hospital. They're usually home. But we know that this is when they're going back to independence, etc. When we're educating mom about the things to report, we know that lochia is important. We know that lochia progresses from rubra to serosa and then alba. If you go from lochia alba, 10 days postpartum, to back to rubra, that is a huge red flag, and she must report it to her physician. If she develops mastitis, how does she know she has mastitis? She's probably going to have unilateral breast pain. And she'll probably have fever, chills, flu-like symptoms. This usually occurs, 3 weeks after they've delivered the baby, because they're attempting to breastfeed. The baby may not latch on properly, and they have cracked nipples. Bacteria gets in there, and you find yourself with an infection. They must report it because it has to be treated with antibiotics, okay? So if they're hemorrhaging, of course, we want to tell them to report it. If they have blurry vision, okay, we want to tell them to report it. If they get headaches that do not go away with, Tylenol, they also want to report it. If they develop headaches with the epigastric pain, remember they can develop preeclampsia in the postpartum period. All right. If they have foul smelling lochia should not be foul smelling. It should smell fleshy, but not foul smelling. Okay. You also want to educate your patients again. What should I expect from the lochia? If you have tissue in the lochia, that's not normal. You can have clots, now you don't want egg-sized clots because that's abnormal too. You're hemorrhaging. But in the clots, there should not be any tissue. If there is the presence of tissue, that needs to be reported because they could have placental remains. Again, the smell of the lochia. Also, nobody should be changing their pad every hour. I mean, they can change it if they choose to, but not because it's being saturated. So if they're saturating a pad every hour, this is something that, we need to make sure that we address, or that we let them know that it's not normal and that they have to report it. In terms of birth control, remember we have the natural family planning that they can use afterwards. We know they're not that effective. Breastfeeding can cause amenorrhea, which is great and all, but it doesn't mean just because you do not have a period that you are not ovulating, okay? Women who can get away with this as a method of birth control are the ones who are exclusively breastfeeding. What does that mean? That means that baby never takes a pacifier or a bottle to his or her mouth. Never. It is on-demand breastfeeding, exclusively breastfeeding, and I'm talking, just strictly the mom with the baby, and even then, the failure rate is significant. So you want to definitely educate your patients on that. We know the risk factors for hormonal birth control. There it is contraindicated, and some of them, the combined hormonal contraceptive, the pill, could be contraindicated the first 6 weeks postpartum. Okay. And then of course we have that state of where women are more likely to develop clots. We also want to teach them about that when they go home. If you feel either shortness of breath, or if you feel like you have one leg that becomes hot, swollen, and painful, you want to tell them that they need to come to the hospital, or definitely at a minimum go see their provider if that should happen. Sibling rivalry is another thing that we need to be concerned with. All right, we want to make sure that parents understand the importance of incorporating their older child in involving them in the whole event of having a new baby. Maybe have them buy a gift and give it to the older sibling and saying it comes from the baby. You want to recommend that they spend time alone with that other child. Okay, that they dedicate some time so that they don't feel left out. Allow them maybe to hold the baby. If they come to the hospital, you want to encourage them to just touch the baby, and also to get close to mom, to maybe lay in bed with mom. Anything that'll make them feel part of the process. Okay. As a postpartum nurse, you also have to remember that your patients are tired. They have been laboring for God knows how long. It could be a day, it could be 2 days, it could be 3 days. We don't know. But the bottom line is that they are very tired. They probably haven't had a good night's rest in a while. So you need to be smart. We want to cluster the care. You're not going to go in to see your patient to take her blood pressure and then come back 30 minutes later to give her pain medications, and then come back an hour later to bring her towels and pads. You want to cluster the care to help them, not just the mother, but also the significant other, so that they can get some rest. All right. Remember, you also have to keep your eyes peeled for ineffective bonding or ineffective impaired attachment. All right. Who is at risk for impaired attachment? People who cannot be with their babies immediately post a postpartum period. If mom has to go to the ICU because she hemorrhaged and is, at risk of developing DIC. If the baby had to go to the NICU for whatever reason, and now mom cannot be, holding the baby all the time. If you have a patient who's a drug addict, that's a big one too, because they're not, they're fixated on wanting to get their drugs and have a hard time with attachment and bonding. The other one is adolescence. If you have a 12-year-old who had a baby, that's going to be a challenge. If you have a 15-year-old, that's going to be a challenge, okay? Because developmentally, they're not prepared to be parents, all right? Remember that when we are caring for the whole family, we also want to take into consideration, the father. We want to also get him involved in the care. Most men will develop what we call engrossment, and you'll see them, looking at every single detail of their newborn, their toes, their hair, their eyes, their nose, everything. That is called engrossment. Remember that. And it is also important that we encourage skin to skin with the father, not just the mother. Okay. Please review again the maternal phases. Remember, in the maternal phases is about what mom wants to eat, how she needs to rest, what she wants to drink, how brave she was during her period, how she has to take care of herself. It's about her. This is when we care for her, and we make sure that she is comfortable and that she just goes through that phase as needed. Know the different styles of communication, parent newborn communication. You have eye movement. You have this thing called entertainment, where the babies move, their hands and feet in a rhythmic pattern. Okay. Babies cry, and they're also trying to tell you something when they cry. When they do cooing sounds, they're also trying to communicate. So please make sure that that you review that. Okay. Know that during the first 2-3 days postpartum, mom is not going to have milk. She's going to have colostrum. Colostrum starts developing when you're around 4 months pregnant, and it starts coming out or easily expressed in the first couple of days. Now she has to put baby on the breast. Once she's doing that, days, after day 3, the milk starts coming in. All right. And you have to teach them that it's okay, that colostrum the first 2 days is enough, that the baby's stomach is really, really tiny. So they don't need a bottle of milk. Okay. They just need, a very, very, very little. The baby's stomach is like the size of a marble, okay? When we're talking to our patients about breastfeeding, remember there's different positions in which they can breastfeed. Which one's the best one? It's whatever's comfortable for the patient. There are patients, for example, if they had, let's say, a fourth degree laceration, she doesn't want to have a baby on top of her abdomen. She doesn't want to be sitting up to breastfeed this baby. So, what would be the best position for breastfeeding? Laying her down on her side, putting the baby on the side, and having her breastfeed that way. It removes the pressure from the perineum, and she doesn't have to have the baby on top of her abdomen. If a woman had a C-section, same thing. That's probably the best position. Now, if she had a vaginal delivery and she feels perfectly fine, then, no big deal. She can sit up, she can do the cross cradle, she could do, any whatever she is comfortable with, the football hold, whatever she's comfortable with. When we are teaching them about breastfeeding, we also want to talk to mom about the benefits. Remember, it helps to stabilize the glucose in mom. It helps to decrease, ear infections in babies, and actually decreases the chances of SIDS. But there are women who either can't. Let's say you have an HIV positive patient, she cannot breastfeed, she has to bottle feed. We want to teach her how to do that. Number one, they should follow manufacturer guidelines. Not what the doctor says, not what the nurse says, what the manufacturer says and how the formula should be prepared. You also want to make sure that they know that they should not be propping the bottles to avoid tooth decay and actually choking. Okay, when you feed a baby, if they only drink half of the formula, you need to discard the rest. You cannot keep it. And also, we need to prime the nipple of the bottle. What does that mean? You don't stick an air-filled nipple into a baby's mouth, because they're going to suck on that air and they're not going to consume any more formula. And if they consume formula, guess what? The air that they swallowed initially has to come back out. So they'll spit up. So how do we prevent that? We kind of, prime, quote unquote, the nipple. So you must fill it with formula before you put it into the baby's mouth so that they do not suck any air. Okay. We also want to teach mom about the care of the baby. If they have a baby who was circumcised, okay, there should not be anything that's foul smelling. They should not be bleeding or oozing anything from the circumcised glands. Okay. If they did a clamp, a Mogen clamp, let's say, or a Gumco, they need to make sure that they lubricate the glands of the penis and that they kind of leave the diaper a little loose so that it doesn't stick to the diaper. If they utilize a Plastibell, which is a different system utilized to do circumcision, it's the opposite. They should not lubricate the glands, because then the Plastibell is going to fall off. It's going to slide off before time. Please note the Plastibell does slide off on its own. It usually occurs within 10 days, 7 to 10 days after the procedure. But in the meantime, we do not lubricate it so that it doesn't slide off before time. Okay, if the child is not circumcised, we tell them not to retract the foreskin. They are not to retract the foreskin. It'll happen on its own when they're around 3 years of age. In the meantime, we make sure that they wash it, that they keep it dry and clean. That's it. No retracting of the foreskin. We want to teach them about the normal stools. If a baby has yellow, seedy stools, chances are they're a breastfed baby, and that would be a normal finding. The first day or so, the stool is going to be dark green, sometimes looks like tar, black, and it is meconium. We know that. If they go home and their baby starts having loose green stools, that is abnormal. Okay, remember, babies dehydrate really fast. So they need to take the baby to the doctor. If the baby is not producing 6 wet diapers in a day, there's a problem. They might need to increase the uptake. Maybe they're only breastfeeding and they're not getting enough. They might have to supplement. But regardless, they should be calling the physician and maybe bringing the baby in for further evaluation when it comes to that. Note, the best time to feed your baby is when they are quiet but alert. Okay, you don't wait until your baby's crying to feed them. That is like too late. You have gone way past. All right, breastfeeding usually occurs every 3 hours. Okay, not breastfeeding, formula feeding every 3 hours. If they are breastfeeding, it's usually every hour and a half to 2 hours or on demand. Okay, we do not want a baby to go more than 3 hours without eating. So please make sure that we know that. Read on colic. Remember, colic usually goes away by 4 to 5 months of age. It's basically uncontrollable crying, and nobody knows why it happens. We really do not understand. Babies will be happy 1 second and then they start crying, and we don't know why. Okay. Remember safety for the baby. We want to prevent SIDS. Okay. We want to prevent SIDS. How are we going to do it? We don't want any bumpers on the crib. We don't want stuffed animals. We don't want loose sheets. So we're going to put one fitted sheet over the mattress. And that is it. If you're concerned with the baby being cold, you have the little onesies, that cover their feet, their hands, and everything else. We can do that. If they are going to swaddle the baby, we need to make sure that they know how to properly swaddle the baby. Remember, improper swaddling can also put the baby at risk for SIDS, because if you don't, do it properly, the sheets, the blanket might go over the baby's face. So that is one of the risk factors, okay? We don't cover them with a blanket. We don't do any of that can become loose and cover the baby's face. We absolutely do not put babies inside the bed with the parents, on the bed with the parents, okay? Babies are not to sleep in the same bed with parents. Why? Because when you fall asleep, you're asleep. You're gone. And if you're exhausted from caring for a baby all day and just trying to recover from the whole labor process in general, if you lay there, you're going to pass out, you're going to go to sleep, and you don't know if you're going to turn over your baby and suffocate your baby. So the babies are to sleep. They have to room in the first 6 months, but in their own bassinet, in their own crib, not in the bed with mom or dad. Okay. Please make sure that you review the rate of infusion for oxytocin. How would we run it? How many units are they receiving? Like how many mLs would you administer if I tell you to give them, 20 units of oxytocin? 20 milliunits of oxytocin. How many mLs would that be? Or how many units is it if you're infusing 100 mLs in a 1000 ml LR bag that has 20 units of oxytocin? So anyway, review. There is a section in your chapters that talks about oxytocin. Make sure that you review that and the administration of oxytocin. Remember, oxytocin is always ran through a pump. Okay, good luck. You guys are going to do great. I'm sorry this is late. I had internet connectivity issues, and I was trying to upload a different file that I had from before, and it didn't work. So here is this one. Have a wonderful and productive weekend.